A very good evening to one and all. I am Arpita, the moderator for today's session from the IGCP group. Welcomes you everyone to the topic that we are going to discuss today is management of corneal infection, viral, bacterial and fungal. Now, managing corneal infection requires specific strategy tailored to the causative agent, whether viral, bacterial or fungal. Corneal infections pose significant challenges in ophthalmic practice requiring prompt diagnosis and appropriate management to prevent vision-threatening complications. To address this very important topic, we have with us none other than Dr. Kuresh B. Maskati sir, who is very well known to all of us. Sir, it's an honor for me to welcome you, sir, and I would like to just give a brief introduction of sir now. Sir has done MBBS, MS, DOMS, FCPS, FICS. He is a consultant ophthalmologist at the Maskati Eye Clinic, which is at Mumbai. So, with this very brief introduction of sir, I would request him to please start with the session. Over to you, sir.
Thank you, Arpita. As you said, it's a very, very vast topic. Corneal infections can be due to various causes: viral, bacterial, fungi, acanthamoeba, protozoans. But let us see at least some salient features that we can get some tips on how to manage in the next few minutes that we have. So the therapeutic approach will be based on the history, clinical exam. Whenever we examine the eye with infection, we must include the examination of the lacrimal sac because it can harbor pus, the eyelids, the adnexa, and then once you've done a clinical examination, including slit lamp exam, then we go to laboratory investigations. And judging from the type of infection that we see and our knowledge of organisms, we can come to know whether it is viral, bacterial, fungal, or which type of virus, bacteria, or fungus. So that is the basic approach. Let us start with viral keratitis. Viral keratitis is more common in the US. It is the most frequent cause of blindness due to corneal disease in the US and the most common source of infectious blindness in the Western world. In India, fungus is about 1/3 of all our corneal infections, but in the US, it is viral keratitis. In the developed world, viral keratitis is the most common. There are two types of virus, herpes simplex and herpes zoster. Herpes zoster is not so much of an issue. Herpes simplex is more common. The prognosis, however, is generally favorable provided we give aggressive treatment in viral keratitis. So the hallmark of herpes simplex keratitis is what is called a dendritic ulcer. First, the lesions start with small raised vesicles, as you can see in the picture on the left, and then these vesicles coalesce and you get a branching pattern like a tree branches. This is called a dendritic ulcer. All the other pictures are dendritic ulcers. The pink one is stained with rose bengal and the others are stained with fluorescein stain. So it becomes very easy to recognize by two things. One is this typical dendritic pattern, and the second is that the corneal sensations become reduced. So when we touch with a cotton swab, the patient doesn't blink his eye. So that is a hallmark that this is a viral keratitis and usually a herpes simplex keratitis. Usually it is unilateral. So the diagnosis, of course, as I said, clinical picture that you can see this herpetic pattern, but you can use different types of stain. You can scrape the cornea and stain with Giemsa stain or pap smear, just like the pap smear which is done for cervical mucosa, which will show intranuclear eosinophilic inclusion bodies. You can do a viral culture, you can do immunohistochemistry, and nowadays the latest kid on the block is PCR or polymerase chain reaction, because you need very little of the tissue and you send it for PCR assay and it can tell you exactly what kind of organism it is, viral, bacterial, fungal, and which type of virus as well. Moving on to acanthamoeba epithelial keratitis. This abroad it is common due to improper contact lens wear. People who don't take hygienic precautions by wearing contact lenses or they swim with their contact lenses on, they get this acanthamoeba keratitis, which is an extremely painful condition. The pain is out of proportion to what you can see on slit lamp. In our country, it is farmers, people working in muddy water, people falling in muddy water, not so much due to contact lenses, because in our country, not too many people wear contact lenses. You get a pseudodendrite appearance. You can even get a wreath-like appearance around the cornea. It's a disease which is difficult to treat. You have to treat for 3 to 4 months. There is no specific treatment for acanthamoeba, but we try antifungal treatment, and the swimming pool disinfectant PHMB can be used, and the dental disinfectant chlorhexidine is also tried in acanthamoeba keratitis. Let us move on to bacteria, because that is the commonest. Almost 65% of our lesions are bacteria. The commonest bacteria, gram-positive cocci, like the staph, strepto, and pneumo. Gram-negative cocci and cocobacilli, like moraxella and gonorrhea. And gram-negative rods, like pseudomonas. And you get, nowadays we are getting a lot of atypical mycobacteria. You know that Mycobacterium tuberculosis and Mycobacterium leprae, which cause tuberculosis and leprosy. But we get Mycobacteria chiloni and Mycobacterium fortuitum, which affect especially post-operative, post-cataract or post-LASIK patients. You get infections due to atypical mycobacteria. Why doesn't everyone get corneal ulcers every day? Because we have, the eye has certain protective mechanisms, which is the eyelids. Every time the eyelids blink about 25 to 30 times a minute, once every 2.5 seconds. So any dust which is there, if there is a dust storm, for example, your eyes will instinctively close. So it's a protective mechanism. If you got facial palsy and your eyes don't blink often, or if you're a computer programmer, somebody who's spending long hours on the screen, then your eyelid blink becomes less. So that is one protective mechanism which goes away. Second one is our tear film. We secrete tears 24 hours of the day, even when we sleep. And the tears contain 3 layers: an outer lipid layer, a middle aqueous layer, and an inner mucin layer. So the aqueous layer or the watery layer washes the eye. So it is just like your at home you wash your floor. So similarly, the aqueous washes the eye. So whatever bacteria have come into the eye or whatever bugs have come into the eye are washed out because of the continuous 24-hour secretion of tears. And the mucin layer, which is the innermost layer of tears, it traps the organisms. So it doesn't allow them to proliferate. It's a sticky thing. Just like for the flies in monsoon, you keep a sticky paper and the flies get trapped on it. Similarly, mucin traps the bugs. And the tears contain also a proteolytic enzymes called lysozymes, which destroy the bacterial cell wall. The third protective mechanism is inside our conjunctiva itself, under the epithelium, is what is called MALT, subepithelial mucosal lymphoid tissue. So subepithelial, because the epithelium is mucosal, the conjunctival epithelium is mucosa. So subepithelial MALT is just mucosal accessory lymphoid tissue. So this contains lymphocytes, which can again attack the bacteria. Most important thing is an intact corneal epithelial layer. Our epithelium, the front layer of our cornea, it's about 5 layers thick, the epithelium. So it has got very tight junctions between the individual cells called with desmosomes and hemidesmosomes. So if the epithelial layer is intact, the poor bugs don't have a chance to get in. But if there is a slight scratch on your cornea, then the bugs can enter very easily. And funnily enough, all our eyes contain normal, healthy bacterial flora which protect our eyes. So they are it's like your security, your watchmen, which don't allow outside enemies to come into your building. So similarly, these normal bacterial flora stand guard in your eye and don't allow the pathogenic bacteria from outside to attack. They kill those pathogenic bacteria. So these are the protective mechanisms which work day and night for you to prevent an ulcer formation. So what are the risk factors? Abuse of topical antibiotics. This is very, very common. Patients with a little red eye, usually it's a viral conjunctivitis, they go to the chemist, they go to the pharmacy, they don't come to the doctor. And they are given antibiotic drops, usually very high antibiotics. And because of overuse of antibiotic, the normal bacterial flora, the healthy bacterial flora in your eye are destroyed, allowing other opportunistic infections with the harmful bacteria and fungi. Worse is people who use topical antibiotic steroid combinations to become better faster. Again, steroid causes immunosuppression, it prevents polymorphonuclear migration, causes rebound inflammation on stoppage, so eye becomes more red, and it gives a great opportunity for fungi to grow. So these are some of the problems that we create, what we call iatrogenic problems. Then some which are not in your control. If the patient is immunocompromised, such as an HIV/AIDS patient, or very malnourished, or a drug addict, or a person who is pregnancy, the resistance of the eye goes down, or patients suffering from malignancy or very old age, these are predisposed to corneal infections. Minor trauma to the epithelium. The top picture, you can see there is a foreign body on the cornea there, and so if you rub the eye with the foreign body, you will cause an abrasion. Sometimes you get large abrasion, as you can see in the middle picture there, that is stained with fluorescein. And you can see that like a skirt which is seen, that's the epithelium which has been cast off and is staining green. And if for any reason, if the cornea doesn't have its nerve supply, because anytime something goes in the eye reacts with a blink and throws away the organism or throws away the foreign body. But if the cornea is anesthetic, then foreign bodies can come and hit it and you will not know, and foreign body may be infected and cause infection in the eye. Those who are contact lens wearers and abuse their contact lens, as you can see in the picture, that's a cosmetic contact lens. If you wear it for more than 8 to 10 hours, the cornea becomes hypoxic, the sensitivity of the cornea goes down, and infections can more easily occur. And sometimes it is iatrogenic. We have done a corneal transplant for some reason, and that corneal transplant, if the sutures are loose or they can get infected, so you can get it following corneal surgery, following cataract surgery, you can get these. So these are some of the risk factors. So we examine the cornea, we look at the epithelium first, which is the outer layer. Is it intact or is it ulcerated? Then we look at the layer below that, which is called the stroma. Is there pus there or not there? What is the site of the lesion? Is it in one corner, like is it peripheral? Is it multifocal, marginal? Is it in the center? Because that gives you an idea as to what the organism could be. The clinical feature which is shared by almost all bacterial and fungal ulcers is pain, redness, and watering. So you see the picture there of that person whose eye is tearing so much, and there is a lot of pain there, and there is some amount of redness. There can be discharge, as you can see. If there is a lot of discharge, we suspect gonococcus or pneumococcus or hemophilus. So if there is a lot of discharge, you suspect this. There could be debris in the tear film. When you pull the lower lid down and look at the tears, there is a lot of kachra-like things over there, which should not be there. That alerts you that this is infection. The eyelids become edematous, and the conjunctiva becomes swollen or chemosis occurs. If you look inside the eye, you can get a hypopion, which is a fluid level in the anterior chamber, as you can see that yellowish white, the central ulcer, and you see that boat-like thing below, that's the hypopion or the pus in the anterior chamber. And of course, the cornea will be ulcerated or there'll be an abscess, as you can see in the lowest picture. So these are the common features for both bacterial and fungal keratitis. In addition, we must not look only at the cornea. We must look at the outside, at the sclera. Has the infection spread to the sclera? Very severe infections can spread to the sclera. Is the cornea showing sign of melting? Is the sclera showing signs of melting, which denotes very severe infections like Pseudomonas? Is the iris inflamed at the same time? Is the pressure in the eye raised? If the iris gets inflamed, then you get the lot of inflammatory debris in the eye which block the angle of the eye, and glaucoma or raised pressure can occur. And you look for rate of progression. Some ulcers progress very slowly, like staphylococcus. Some progress very fast, like Pseudomonas or fungal. So if it is progressing fast, then you get to know, you can make some sort of that gives you a clue to the diagnosis. Of course, we don't rely only on clinical features because it can fool us many times. Culture is the gold standard. And in Bangladesh, they did a study of 127 patients with microbial keratitis, and simple gram staining was done. It was positive in 70% and culture was positive in 85%. So we should all be doing laboratory investigations to find out what the causative organism was. So we scrape the ulcer. Ideally, before you start the antibiotic treatment, when the patient first comes to me with an ulcer, I will scrape and send some tissue for staining with either Giemsa stain or gram stain, and a little bit of the tissue I will send for culture. If the patient is already on treatment from somebody else, and if the keratitis is mild, I will withhold treatment for 12 hours. Otherwise, I will not get a positive culture and then scrape. However, if the keratitis is severe, you can't wait there, you must scrape immediately. So you can use Giemsa stain. You can see bacteria which are stained dark blue, as you can see in the picture. The fungal hyphae will stain light blue or purple. And below you can see cysts of acanthamoeba, which can also be seen. So simple staining can give you what the organism is, bacterial, fungal, or acanthamoeba. We have newer diagnostic tools like confocal microscopy, which is expensive and is difficult to interpret, but you can see it like a slit lamp itself without having to scrape. And I told you about PCR, or polymerase chain reaction. Advantage being that it requires very tiny amount of material, but it's a little expensive, so not every center has got this. What are the treatment goals? Now we've identified, we have done a culture, we know what the organism is. We must try to eliminate the infective organism rapidly and reduce the inflammatory response, because otherwise you'll get rid of the infection, but the eye will also collapse. We don't want that to happen. We don't want structural damage to the cornea, and you must quickly try to promote healing of the epithelial surface. So some of the commonly used antibiotics, the cephalosporins, the first generation was cefazolin, but now we go to the third generation, which is ceftazidime. Trade name, one of the trade names is Fortum. I have no financial interest. We use vancomycin, which is for gram-positive organisms. We make eye drops from it. Advantage being that because vancomycin is not freely used in medicine, the resistance to vancomycin is reduced. So when we don't know what the organism is, we treat with a combination of gram-positive killing, that is vancomycin, and gram-negative killing, which is ceftazidime. You can also use aminoglycosides like gentamicin, tropramycin, amikacin. We normally fortify them. That means we add one injection gentamicin to drops gentamicin to make 15 milligram per ml, which is higher than the dose which is there in the eye drop bottle. And nowadays, since the last 15 years or so, a newer group has come in, which is fluoroquinolones. So the third generation cephalosporins, I told you, ceftazidime or Fortum, which has a good action against gram-negative bacteria like Pseudomonas, and vancomycin, which is a glycopeptide, which has a better anti-gram positive action against Staph aureus, Coagulus negative staph, strepto, pneumo. It can be given, but we don't give it subconjunctival. It may cause sloughing. And as I said, aminoglycosides can be given, but they need to be fortified. So we add the injection to the eye drops to make 14 milligram per cc. But you can't use it for too long because it causes surface damage. Fluoroquinolones, I told you, are bactericidal. The earliest ones was ciprofloxacin and ofloxacin, but their organisms are now developing resistance to these. Important thing to remember is there is no patching. Many times I've seen corneal ulcers treated by a family physician with an eye patch. Don't put a patch because the bacteria grow when there is a warmth provided by the patch. So instead of that, you must leave the eye open. And loading dose concept means that first, when you put the drops, you put it every 1 minute for 5 minutes, then every 5 minutes for half an hour, then every half an hour the first day, then every 1 hour the next day. So very high frequency. Drops is always better than ointment. If the patient is going to sleep at night, you can put ointment at night, but drops during the day. Subconjunctival injection can be given for patients who are not compliant and they're not going to put the drops. But every drug cannot be given subconjunctival. Sometimes it will cause a lot of pain, and even scarring can be done, can be seen. So you must choose your patients carefully for subconjunctival injections. Then you modify the therapy based on the clinical response and the lab reports. So suppose you started with, say, vancomycin, for example, but then your lab report comes that it is gram negative, then you stop the vancomycin. It won't work, and put the patient on Fortum or on a fourth generation fluoroquinolone, which acts on both gram positive and gram negative. Aside from just drops, we need to do some adjunctive therapy. If there is a plaque of necrotic material there, then the drug won't penetrate unless you remove that plaque. So you do a debridement. If you want the eye drops to remain in the eye longer, we can put collagen plugs in the puncti. So you block the puncti just like you block a basin with a rubber bung if you want the water in the basin to remain longer. And of course, you give oral painkillers for control of pain. Topicals don't work. If there is glaucoma, you will give anti-glaucoma drops. And one drop which is common to all infections is atropine, because atropine relieves ciliary spasm and alleviates the pain and prevents synechia. Don't use any contact lenses unless all infections are eradicated. If there is a perforation, you can use some glue to close that perforation. What about steroids? Never use steroids while the ulcer is improving, only after the infection is controlled to reduce the inflammation. And along with the steroid, for some time, you must use antibiotic cover as a must. Avoiding thin corneas or impending perforations, otherwise the cornea may melt. Start with a low dose, infrequent dosing. If there's no damage, then very cautiously you can increase the steroids. But again, I say never give steroids in an active ulcer. Let's move on from bacterial to fungal ulcer. According to WHO, corneal diseases are secondary only to cataract and causing blindness in our type of countries. And we get almost 1.5 to 2 million new cases are added every year. In a study in South India, 44% of all central corneal ulcers were fungal. And so we know that the fungal is at least a 1/3 in all pan-India figures as well. In the West, because the climate is different, they hardly see any fungus. Predisposing factors, we are primarily an agricultural community. 60% of our patients live in the villages. So trauma with vegetable matter, more chances of fungus. Contact lenses, also more chances of fungus. And if you use steroids, the fungus chances are much higher. Other risk factors are dry eye and post-LASIK surgery. Clinical features, these patients will come late to you because there's not much of redness, there's not much of inflammation. So the early cases, you might think it's viral keratitis. So it's indolent, means very slow progressing. It's a dry, leathery, it's not a wet eye. And we got a raised surface usually, but has great variety of presentation. If you see a pigmented ulcer, then 100% it is fungal ulcer. They can have feathery borders. It can have satellite lesions, as you can see in the upper right. There is one ulcer and then there is one on top. Almost 55% of them will have some hypopyon, and with an irregular height, you see the hypopyon is so high, while in the bacterial one, it was a very thin hypopyon. You see the picture with brown-black pigment on the surface. These are called demataceous fungi, and this is the hallmark of fungus. You need to scrape, and otherwise, if antifungal will not act. And you can get an immune ring, almost like a wedding ring type of picture. And you can get abscesses at the back of the cornea as well. So again, the hallmark is laboratory. You scrape it, you stain with KOH or potassium hydroxide, and this is very cheap and very simple, and almost 90% of the fungi can be seen. You get filaments, you can get yeast-like thing, and of course you can culture. The favorite medium is Saburad's medium for culturing, and this is what you see in the bottles that you're seeing, the culture-rich growth. PCR can be done, confocal can be done, of course, but many a time you may get a negative result as well. The limitations in bacterial therapy is very good because the antibacterials are bactericidal, but most antifungals are fungistatic. So it is difficult. It can only prevent progress, but to eradicate the fungi becomes a little difficult. The commonest use is natamycin 5% solution, which is the drug of choice for filamentous fungi. In our western part of India, where I hail from, filamentous fungi are very common, and so natamycin is the one which is used. You can see the filaments in the lower right slide. Amphotericin B can also be used both intracameral, that means within inside the eye. If there is an infection at the back, intravitreal can also be given, subconjunctival can also be given. It covers candida and aspergillus, but not so effective against fusarium. You need to scrape the epithelium before using amphotericin B, and you get another class called azoles, of which the common newer one is the voriconazole. Natamycin and voriconazole have almost equal efficacy. In summary, the diagnosis and management of fungal keratitis can be challenging. The microbiological laboratory backup is useful. Prolonged medical treatment and prompt timing of surgical intervention increases the chances of cure. So in fungal keratitis, some of the other options are surgical debridement. So you reduce the fungal load and then if the fungus has gone into the anterior chamber, you can do a wash with amphotericin B. And if the cornea is getting thinned, we can use a tissue adhesive like a corneal glue and put a bandage contact lens. Sometimes we have to do some the stronger surgical options like an amniotic membrane transplant, or we have to do a therapeutic keratoplasty, as you can see in the bottom picture where I've done a corneal graft which has remained clear. You might do an excimer laser PTK, that means instead of scraping with a knife, you can scrape it with an excimer laser, or you can do a conjunctivoplasty if there is impending perforation. You cover the cornea with conjunctival tissue so that you can continue to treat it and the cornea will not perforate. To end with, what are the common causes of non-healing ulcer? Ulcer which is not healing because you're given the wrong medication. It is fungus, you're given bacterial, antibacterial. With bacteria, you're given antifungal, or you're given over abuse the drug, so the drug itself is causing toxicity, or you've given inadequate dosage, just 3 times a day or 4 times a day, it doesn't work, or you have told the patient to put the drops every hour, but patient is putting it 4 times a day, so compliance is poor, or there is mixed infection which you have not detected, you're treating only bacteria when there is a combination of bacterial and fungus, you have not taken care of the secondary glaucoma, or you have not taken care of the focus of sepsis. For example, the lacrimal sac is infected and it is pouring pus into the eye, and you should remove that lacrimal sac by surgery. So in chronic dacryocystitis, or the lid is not opening and closing well, you need to close the lids with a small tarsorrhaphy. So these are some of the common causes where in spite of your best efforts, the ulcer doesn't heal. Thank you so much for your attention, and I'll be very happy to answer questions.
Right, sir. Thank you, sir. Thank you so much for the wonderful presentation that we have seen just now. So, meanwhile, I have also received a few questions from our audiences.
Yeah.
The first question that has come is what is your protocol for monitoring patients during and after treatment of fungal keratitis?
Protocol for? Can you repeat the question, Arpita?
Just 1 minute, sir. The question is what is your protocol for monitoring patients during and after treatment of fungal keratitis?
Yeah. So in fungal keratitis or any keratitis, you must not just prescribe medicine and call the patient after a week or 10 days. It may be too late. You must either, if you have admission facilities, you must admit the patient under you, or at least call the patient initially daily or every alternate day till you find the patient is on a healing path. Then you can call him after every 2-3 days or so. So this is the protocol I follow for the patients during the fungal keratitis and after. And don't be in a hurry to start steroid in fungal keratitis. Wait for at least a month or so, and only then very cautiously you can add steroid to prevent opacity from forming. Thank you.
Thank you, sir. Thank you so much. Another question is what are the most effective methods for obtaining and processing corneal samples for bacterial cultures?
So if you are in a tier 1 city, then it is easy for you because you have good laboratories. You can scrape and immediately put it in a medium which the laboratory will give you, and transport it to the laboratory. What I do in Mumbai is that I have tied up with a large hospital which has an eye department as well as a good pathology department. So I send my patient with corneal ulcer to the eye department. The resident doctors there scrape it and immediately send it to the lab, which is just one floor below. So no time is lost and they can easily culture it. If you are in a tier 2 or tier 3 city, then you must invest in a pathology microscope yourself and at least do the scraping and put a drop of the gram stain on a drop of KOH and look yourself under the microscope, because you can't depend on the laboratories. They have not seen too many eye samples to give you a correct diagnosis. So you have to become your own pathologist, as it were. Thank you.
Very short but a very practical like solution that you have given, sir. We'll take last one question. How important is interdisciplinary collaboration in managing complex corneal infections?
Arpita, interdisciplinary is the way to go. We all think that we are the greatest gift to mankind and we know everything, which is not true. So you must collaborate with your peers. So many times I have a patient who's got a corneal ulcer. The patient has got rheumatoid arthritis, and that is why he's got dry eye and corneal. So I will talk to the rheumatologist and ask him to treat and increase the immunosuppressives so that the eye gets better. Pathologists, I need to talk to the pathologists all the time and tell them, I'm suspecting acanthamoeba, can you look for it? Because many times if you tell them what you're suspecting, it is much easier for them to pick up rather than sending the sample and saying find something, so uh, and many times the infection has gone to the from the cornea, though we are talking today only of cornea, but the infection has gone to the back of the eye. So I need my retinal specialist, my retinal colleagues, because he has to give injections in the vitreous, intravitreal injection of amphotericin, which I am not qualified to give. So it has to be a team approach depending on what the case is. Thank you.
Right, sir. So what sir is telling is to go ahead with the rule of synergy, which says 1 plus 1 is not 2 and 1 plus 1 is 11.
Absolutely,
Right, sir.
Arpita. Yeah.
Right, sir. So that was the last question for today. So, sir, with that note, I would like to first thank you for enlightening us with your knowledge, with your wisdom, and of course, thanks to all the audiences for attending our session, for putting their questions and making it a successful one. So, thank you once again, sir, for giving us your precious time. Thank you
Thank
so
you.
much, sir. Thank you.
Thank you. Thank you.
Conclude the session
Okay.
here. Thank you.
Thank you.